There's no percentage, it's only 70 meters. So 850 meters is the height of that structure. And because it's a desert, there is no ground root ratio, it's less than 10%. It's less than 10%. Petronas Towers is about 120 meters. Guess for the World Trade Center, how much do you think was the foundation there? 70 feet. What about, I'll show you pictures. What about MetLife building? 0. Because Grand Central Station was right there, 100 years before that. The structure just came up from nowhere. Because Manhattan is built on Manhattan schist, the strongest rock on earth. So you don't need foundation at all. So if you're driving through, you see these skyscrapers come through, you'll never hear a pile foundation. So it differs, architects use what's called as soil density. That is the relationship of how deep we should go in based upon the resistance to the weight that we are going to be using. So if I translate that, you said less than 70 feet, this is the pit. The pit at the World Trade Center was like this. There's absolutely no concrete foundation. Even in World Trade Center, number 1 World Trade Center, there's no foundation. Right, so that's why they just built it from the ground. In fact, the 70 feet was filled with PATH station, mall, you have all these parking garages, right? That's why it's hollow. So how can they do that? They can do this based upon the reciprocity of the foundation. So now bring this in the mouth. If you bring this information in the mouth, where would you need the longest implant? Type 4, right? That's where technically you would say you would need long implants. But then, how is the short implant being used in the posterior maxilla? It's different, right? So it is not just the length, it is the BIC, bone implant contact. The bone implant contact is the sum total of the surface area that's actually coming into contact with bone. So denser the bone, shorter the implant. Where do you use the longest implant? We use the longest implant in the anterior mandible when it's not even needed. In fact, in the anterior mandible, you can do with 5 mm implants, and they should work just fine, because it's all in dense bone. So that's why many of these short implants can be validated in terms of the ground root ratio. So let's look at the literature. 10-year prospective study of the posterior implants with short foundation. So they're saying implant ground root ratio can be 2 to 3 times. That is, this can be 2 times and this can be 2 times. Can be used very successfully. And that's how Bicon has a role to play. The Bicon images are not photoshopped. They're real. They do have a place. But they don't have a place in my practice for different reasons. I'm a prosthetist. I would like screw-retained restoration. Bicon, you cannot do screw-retained restorations. I do a lot of overdentures. I cannot do overdentures. I do a lot of hybrids. I cannot do hybrids. I splint sometimes. I cannot splint. I cantilever sometimes. I cannot cantilever. That takes away 75% of my practice. That's why I don't use it. But does it have a place? Certainly it has a place. If you have a nerve that's riding very close, and I only have 5 millimeter implant, 5 millimeter bone, I don't mind placing a 5. It'll work. So what are the parameters that's going to make it work? It's not just the ground root ratio alone. You need to think about force vectors. So in the maxilla, if I have bone like this, and the sinus is very, very close, okay, the sinus is dipping down, and now I have to have the mandibular arch also restored. Okay, I've got the mandibular arch restored, and then I have the nerve which is coming very close. I'm going to place a maxillary implant, which is a short Bicon implant. It's also short, okay, and I'm placing a short implant here and a short implant here, and then I'm restoring the mandibular teeth, okay, like this, and now I have to restore the maxillary arch like this. Okay, so now I have a maxillary restoration like this, and in the mandible I've got a restoration like this. Okay, in terms of the outcomes from 1 to 4, okay, so I will write the different sections. Let me say this is 1, this is 2, this is 3, this is 4. Can you predict the outcome of these implant restorations based upon what you know? Which is the best prognosis? Which has the worst prognosis?
3 is the best.
3 is the best. Okay? Now, next. Next.
2 is the worst.
1 and 4 about the same. Which is the worst?
2.
2. What's going to fail? Osseointegration or the prosthesis? What's that? Osseointegration will not fail.
Screw.
Screw will break. That's what we just now read, that crown root ratio does not apply to implants. Okay? You can put your implants any direction. Osseointegration will not have a problem. The fracture of the abutments, screw breaking off. It's a biomechanical complication that will result if you don't use these short implants properly. There is no preponderance of bone loss just because you put the implant at an angle. If that was a problem, all of them would all fail. Right? So angle and implant loss is not a correlation. So it's mostly a biomechanical failure that we see happen in these cases. So you should have the prediction. If it's a single tooth, I'm an engineer. How am I going to design my restoration? If I want longevity, how do I correct the problem of number 2? Which kind of scheme can I use to make this better? Crossbite. Absolutely. So if you restore the case in crossbite, that implant is going to be beautiful. So every case that you're going to check in eccentric, because you're putting implants parallel, your crown's going to go too far to the buccal. Look at the amount of cantilevers. For a single crown, spend time. So 1 is crossbite. What if the patient says, why is this crown inside? Then what would you do? Custom abutment still will not change the force direction. Custom abutment is only going to give you that position of the abutment where the tooth is going to be. Still the relationship is a cantilever. So what can we change in the design of a crown that can make narrow table? What else? Decrease cuspal angles. So Weinberg's article, for every 5-degree change in your cuspal angle, the torque values change 25%. So instead of having a class 1 like this, we will take this, reduce it, and then bring it down. So your occlusal scheme, if you want cosmetics, it will be like this and have no excursive movements. Centric contacts only in that line angle. The cusp is only for cosmetics. The cusp is only there just for show. It should not engage or participate in any excursive movements. That's what you want to do. So this is again, that's why it takes time to study your prosthesis. Unfortunately, 90% of this course is geared towards surgery. We really don't pay attention to prosthetics. And that's what finally counts. At the end of the day, patient's going to look at this and say the crown. He doesn't take an x-ray and say, oh, your implant has got a 5-degree angle, why do you change it down? There is no question about the surgery because everything is buried. Okay? Spend more time on refining the prosthetics so that you don't give a lot of weightage to your labs.
What do you do if you start getting cheek biting?
Cheek biting only happens in a crossbite if your overlap is too much. Right? If somebody's face is sunken in. All right? In those cases, you're going to try and get the lower as far possible towards the lingualism.
So right now in the situation 2 and 3 with the green,
With the green, yeah.
that's
So
possible for...
that's possible. That's perfectly fine. You can still have a class 1 with only the lingual contact. Then cheek bite won't happen. Now I'll show you in all of my prosthetic designs how you should be designing it. Okay? So if time permits, I'll show you my occlusion lecture. Alright, so that's your crown root ratio, and we'll see what are the factors influencing short implants. So if it's short, as long as it's in the line axis of your mastication, we should be good. Platform stitching may have minimal role in dissipating the forces. Okay. So finally, it's the bone implant contact. Current literature shows that crown implant ratios of implant supported reconstruction does not influence peri-implant crystal bone loss. Okay? So it's not the bone loss that we should be worried about. So how do I validate this? What does it mean to me in terms of my length? I'm wasting all this money in my vertebra. I'm pushing the bone up so I can get a nice dome. I'm doing my crestal lift so I can get a 11.5 instead of an 8 millimeter implant. How much of force is actually transmitted to the apex? What percentage? If it was 100% on the crest, how much force is actually going to the apex? Any clue? I mean, we spoke about crown root ratio. You know this because it could be the difference between hurting somebody with paresthesia or using a short implant. It's important, right? So you should know what is the sum total effect, or if you're placing a crestal lift or a sinus lift, do I aim for a 15 millimeter implant as opposed to a 10 millimeter implant? Do I have to add 6 grams of bone and have long implants, or I can just do a crestal bump and stick with a 8 millimeter implant? Okay, so that's going to impact. So here's a case which will validate the force transfer and the quantity of force transmitted to crest versus the apex. Tooth number 13 has a periapical lesion. Extracted the tooth. This was a referral case. I'm seeing a very mild periapical radiolucency on number 12. Well, I said it's far away. Let me go ahead and place an implant there in number 13. So I did a crestal lift. Okay, this is the crestal lift. You can see the apical puff. We didn't have denser burr. I just used my osteotome. And I told my referring dentist, please take care of this as soon as possible. So she did the RCT. And by the time I got to see the case, the periapical lesion had already spread to the implant. What do? We need to treat that. Maybe I have to do an epicoectomy, and maybe I have to go and explore what's happening at the apical regions of number 13. So the patient was referred back to me. You can see the fistulous tract coming out, but the implant is solid as a rock. Yes?
Dr. Iyer, I've heard before if there's a root canal in the tooth that's extracted, there's the bone in that area is not as vital as if you were taking out a bite. Like something about the root canal treatment, it causes the bone to not be as receptive to an implant. I mean, have you ever seen like a...
Only if you do it as a flapless procedure.
Okay.
If you do it as a flapless procedure, you're unable to visualize the strands that are left behind. So if your technique is good, the success rate is just as good as a direct placement.
Okay.
Because talk about infection. Is the periapical lesion contain bacteria?
Yes.
Then antibiotics should clear it up.
Yeah.
It doesn't. What's the treatment for the periapical lesion? Antibiotics?
No.
Will antibiotics take that lesion away and it will become radiopaque?
No.
No. So there's something there. And what is that? Infection is history. This is affected tissue. So this is not infection. So if I cultured the periapical lesion, you will get 0 bacteria. This is an antigen-antibody reaction. This is autoimmune response to an offending agent that was there. The damage has already been done. So the toxins emanated at the apex is what's causing this. So only a physical debridement is the management. So antibiotics, putting some tetracycline powder on top, amoxicillin on top is not going to work, because they don't work by topical application. So you need to get in and remove it. So physical debridement is the only option. So I'm going to open this up. You can see a periapical opening there, peri-implant opening. So I'm going to curette this, and you can see the half the implant is pretty much exposed. So do you think I can go to the lingual aspect of the implant and curette all of the threads? Is there a device available to go to the lingual aspect of the defect and remove all the granuloma? It's not there. So which means what? What does this image tell you? How much of the apex of the implant contributed to support of this crown? 0. So exam question would be the occlusal loads. 80% of the occlusal loads is transmitted to the crestal 20%. So since this was of no value, I'm taking a carbide burr and I did a epicoectomy of the implant. So cut the tip of the implant off. You can curette all of this away, right? And now it becomes cleaned up. Okay, and then you can grab the site, you can augment the bone. So basically what I have now is a short implant. Okay, so this is what is there now, and this is what was there before.
Why couldn't we do the same with the root? So retreat, open, cut.
Yeah, the problem is the roots have multiple channels.
Oh, okay.
The root is not one apex. I mean, you will have seen the photoelastic model of the dye. The dye penetrates. The dentinal tubules is not one apex. The dentinal tubules goes up to the cementum. So just because you have filled the apex doesn't mean the lateral canals don't exist. That's the problem.
Did you do an apical on the bicuspid also?
I did an apical on the bicuspid also, yeah. So that further validated the theory that the longer the implant is only for stability. 0 load to the apex. The only time you'll have some transmission is when you use zygoma, because the whole thing is hollow. The zygomatic implant, the base is right there because the rest of the stuff is hollow.
When you say stability, you mean initial.
Initial stability.
That's
And afterwards doesn't matter. Exactly. That's very important. And when did you need the initial stability? Which condition?
Immediate.
Immediate. Exactly. So if you're not doing immediate, you don't need long implants. Do you follow what I'm saying? It's simple common sense. You now think about what is really going on with osseointegration. Integration is the direct communication of bone. You can have all the bells and whistles of the implant, doesn't matter. It is the bone and implant contact that makes it work. All right?
Find the literature
This-
where we can, like review or if something happens.
I'll send you tons of literature. So when you talk about short implants, this is further validation.
So are you saying, so the go-to is that if you have you wouldn't do a sinus lift, so you would just put an 8mm?
That's enough. If
implant?
I have, exactly.
Always?
If,
If it's like a routine, no, if it's a routine single implant, not like the other stuff.
yeah, routine, yes.
8mm.
So when will it change? It'll change, let's say the tooth is in crossbite. There's a buccal defect, I have to do augmentation. There's a big concavity. Those cases, I would change, right? So if I have a case where
Because the last lecturer said that according to his recent studies with the journal or whatever it
Yeah,
was, it says that there is a decreased failure, there is an increased failure rate for D4 bone, 10mm, and less than 10mm implants in the posterior right side.
yeah, so that again, you have to look at the confounding variables. The design of the implant, all right? What kind of modality was introduced into that surgical technique? Was it immediately loaded? If that was the case, then we shouldn't be doing implants in the posterior quarters of the mouth. It was the case with Charlie Berman, 1993. There was increasing failure rates with type 4 bone. They blame it on the bone. It was, that's old literature. The current literature does not validate that. The current literature says, as long as you have bone densified, you are giving it the 4 months, the success rate should be controlled.
And how short can you go?
How short can you
How
go?
short do you feel comfortable implant?
I'll show you. If you can go with a length of 8 millimeters with no cantilevers, I would do that with you.
Okay.
So then, why are mini implants like the ball attachment, like interlock?
Yeah.
Why are they long?
It's a different indication.
Yeah.
It's
okay.
immediate load.
That's it.
Exam question. It's immediate load.
So if you don't immediately
Load it, you can do it as a
Doesn't
two-stage.
matter.
So if you're saying if you have posterior implants in the maxilla, if you're wider and shorter, two-stage, you'll have a
Perfect.
class success rate.
So it's identical.
So you don't put healing
Marco
buttons?
Esposito. Okay, that's his article. Marco Esposito's lit review, which is a systematic review. I'm going to give you that. If you want, I can get you this entire. So remind me, I give you my email ID. Feel free to email me. I'll give you all the literature regarding short implants.
And you do no healing button more than 8 millimeters, is that what you're saying?
So if you have a short implant and you put a healing button, it's subject to micro movement. So don't do everything in one shot. Even anteriors, I like to go to stage all the time. I do not do, so you showed me, if I can share the information. The surgeon said, oh, let's put a ovate pontic. That's the wrong technique. If you're going to keep the extraction socket open with the tooth sticking inside, you're never going to get epithelialization. There's something called as contact guidance and contact inhibition. Contact guidance is meant for GPR. Contact inhibition is what makes the epithelium grow over connective tissue. So you should know the biological mechanism with which these are made. So all of the two-stage, which I do, okay, so
If you take a front tooth out and you're doing a two-stage, you just use like a flipper.
I'll absolutely. If I'm going to do it for immediate placement,
For not immediate placement, if you're two-stage.
a two-stage, yeah, in a heel ridge. So if I will go, and I'm going to show you some techniques on grafting too. So this is a simple case, okay? Nothing fancy. Everybody here should be able to do this. There's not one thing here that's a secret, okay? Is a tooth with number 8 is going to be extracted. So what are you looking for? You're not looking to place an implant. You're going to look at benefits versus risk. Is it a 3-unit bridge or am I doing an implant? So this is being calculated by evaluating the soft tissue, probing depths, texture. The tooth is going to be extracted. Okay, so you saw the tooth that was, okay, so this is the tooth you're going to extract. Okay, so before you extract, what is your checklist? Condition of the tooth, any fistula, probing depths, mobility, symptoms, soft tissue profile, diameter of the root, length of the root, distance from the root to the adjacent tooth. So you must have that 10 things in your mind that should be checklist. That checklist should have all of the things that you're looking for. Then you decide, am I extracting and doing immediate placement, extracting and graft, extracting and doing nothing? And if I'm going to place a graft, how soon I want my graft to be turned over, what's the membrane I'm going to place, if it's a membrane, is it resorbable or non-resorbable? If it's resorbable, is it have memory or no memory? Is it going to be covering the entire socket? Am I sliding it into the socket? So those are all the variables you're going to be thinking through. Next step, so extraction. What instrument am I going to use? Am I using a piezo? Do I have a scalpel? Am I using a periotome? Am I using a luxator? Am I using a forceps? So again, that's a checklist. So those are the instrumentation. Next, of course, is the fee. How much do you want to charge the patient? Right? So you got to think about every step because the patient wants to know what is my out-of-pocket. So that visit, when you're looking at the x-ray and the clinical scenario, is going to give you that information of what is a fair fee to charge. This is not a regular single tooth implant, so the fee is different. A single tooth implant in the posterior has a different fee than a single implant in the anterior. So in your mind, you're thinking, I'm going to now grow the soft tissue, which means there's a second visit of stage 2, which I have to make a provisional to create my contours. it's going to take more time. All I have in my practice is to be able to sell my time. If it's going to take additional time, it's additional fee. That's it, simple. Right? You see, the lawyers charge you by the second. You dial the number, the meter starts ticking. Dentistry is the only profession you are paid for your sweat. Right? The patient will say, oh, you took the tooth out in 5 minutes, you're charging me $500, or you want me to take it off in an hour? Keep pulling it for an hour. Yeah, and pretend you're doing something else, right? So that's our block. We feel we have to be, compartmentalizing our treatment. Maybe we should have 3 visits, the patient will feel that they are getting their money's worth. It's all about efficiency. So if it's going to take me an additional visit, my fee is more. The patient says, you know what, I'm really cash strapped. Do it with the minimal intervention. My coverage does not permit me to pay for provisionals. Fine, no problem. So I will still be able to do it. So I have the extraction technique all calculated. So I check my extraction socket, I check the length of the root, I check the diameter of the tooth, and then we will evaluate the soft tissue profiles, the extraction. Take a moment, absorb the extraction socket. What do you do when you see an extraction socket? Take your probe and check all the walls are there. Take your probe and see where the CJ is in relationship to the adjacent bone. Check the thickness of the buccal plate. Then look at it from a prosthetic perspective. Look at the biotype. Look at this tooth tissue. So now I'm looking at what's the likelihood of this papilla shrinking. So I'm doing everything I can not to crush that. Okay? Do I have enough space and slack to be able to get primary closure if I'm placing an implant? If I'm placing an implant, where should the implant be placed? This is the line I'm drawing. So if I'm going to place an implant, if this is the confines, my implant platform should not cross this line. So this is what we meant by the exam question. If I'm doing a symmetry retained restoration, it can go here. But I would like my implant ideally in line with the singular. So my implant has to be here. Which means, should the implant be 4 millimeters, 5 millimeters, 6 millimeters? What's the diameter I should be planning? So all that is being planned not from a surgical perspective. It's being planned from a prosthetic perspective. This is my size of the tooth. Mesiodistally, how much size do I have? So I'm going to pick a design that's going to be ideal to support that. I do not want more titanium in my socket. I want more bone in my socket. Okay? Titanium is a deterrent to my soft tissue planning. So when I think about the placement, then I'm looking at my trajectory. Here's the apex of the implant, of the tooth. So where should I be placing my implant? 2 to 3 millimeters palatal. Should it be parallel to the palatal plate, or should it be parallel to the socket, or should it be parallel to the facial socket? Parallel to the apical third of the palatal wall of the palatal bone. Okay? Not parallel to the wall. Okay? Because that will go towards the facial. So if that's the case, what should be my angulation of the drill? What's the first drill I'm going to use? What's the pilot drill? Because different companies have different pilot drills. Yeah, but if you use a Zimmer, it's too short. Your gold drill is short. No longer.
Doesn't it depend also if you're going to use a screw retained as opposed to a cemented?
Yeah, let's say, yeah, correct. Don't always aim for screw retained because it will come out through the facial. Screw retained doesn't mean it's superior. Screw retained only means your implant is going to come very close to the facial. Screw retained will mean you have to put bone in the front. Okay? The safest is cement retained in the anterior. Okay? So think about the prosthetic angle too. I'll tell you why screw retained is going to be deleterious. Okay, so you've got this. So now I'm going to think about the placement. The placement is going to be dependent upon. Okay, so let me quickly go through the sequence of placement. All right. This is the reason why we don't go through the palatal wall. So if I went through the palatal wall, I will go very close to the facial plate, it will perforate. This is the cross section of the dried skull. Okay? So I'm going with the tooth. So based upon this, my direction is going to be in this pathway. So it's parallel to the palatal wall. And then where is it coming out? It should be enough to be able to provide an abutment and not put the platform to the facial. Okay? So this is another image you should keep in mind before you take your drill and start placing the implant. Think about what is happening inside because you have no access to the interior aspect of your osteotomy. So when you're placing it, you got to take the osteotomy and create a receptor site that's going to be in this direction. So this will have a connotation with the depth of the placement. That's why we say place it 2 millimeters below the CJ. Why? Because you want a running room. And look at the facial. I want 2 millimeters of the facial plate thickness. This is your gateway to success. If you're going to do screw retain, you end up placing an implant like this because your screw axis is here. And if your screw axis is here, now you're going to have a problem on the facial.
So what does immediate? We don't
Parallel.
use the-
Never use the facial. Facial is a disaster. You want to be 2 millimeters away from the facial. So narrower implant, more engagement in the palatal plate, and you're going to go parallel to this. This is a very, very depictive slide that you should keep your mind etched on. This is the reason why they're doing PET therapy, partial extraction therapy. If you do this, you don't have to do partial extraction therapy. That I think is work in progress. So don't do any partial extraction therapy. You all know what it is, right? If a tooth is discolored, you cannot do that. If the tooth has periapic lesion, you cannot do that. You can do that only in a vital tooth. Okay, and you know about the issues with continuous facial growth. With the jaw growing, the root is going to start erupting into the socket. So it's a disaster waiting to happen. So don't do PAT. If you do this and graft it, it's more than enough. Okay? So you want to avoid getting your implant in this state. This is your worst nightmare. And I can show you hundreds of my implants which I made mistake. I used to think I want to go screw retain. I ended up exposing all my implants. Okay? So be very careful about where you want to position it. Narrower diameter, palatal placement. Okay?
For the crystal position, you keep the subcrystal.
Subcrystal 2 millimeters below the CJ. Yeah. So again, I'm drawing a line which is going to be contouring the adjacent. Right? So that is my distance. If I can get that distance, that should be a good way to make sure that I have 2 millimeters of buccal plate.
Fill the gap?
So the gap can be augmented if there is adequate space. You don't have to augment it if it's less than a millimeter. Because blood clot is going to fill.
That jumping distance.
Jumping distance up to 2 millimeters, you don't need graft. Okay?
Because what if the buccal plate to begin with is very thin?
It's not there. Buccal plate not there is not a big deal. That's why you need to know what is the difference between osteogenesis, osteoconduction, and osteoinduction. Okay, so you have a titanium there, right? So there are 2 pieces of bone that is there. So I'm going to give you a scenario. So I don't worry about the buccal plate at all. In fact, buccal plate won't even matter because the buccal plate anyway is going to resorb. So if I have bone like this, I'm going to give you 2 pieces of bone, no facial plate. I have an implant that I'm going to place, and this implant is placed like this. And this implant is placed like this. And I'm going to graft both sides. Okay, so let me put graft here. I'm overbuilding this bone, and I'm building this bone here. Which of these 2 instances you're going to get bone over the implant? Absolutely. So that's what is called as osteoconduction. The top one will be osteoinduction. None of the materials are osteoinductive. Osteoinduction means it induces bone in a non-osteogenic site. That's true osteoinduction. Osteoconduction is appositional growth going across. So if it is titanium, it's osteoconductive, bone will simply march through. Okay? So if I get this, this is all we need. So even though I have no facial plate, as long as the 2 edges are talking to each other, bone's going to go right through. Right? So if you're coming in the way of their communication, bone is not going to go through. Okay, so that's an important aspect of your consideration. So when I'm doing a placement, I'm always looking at these factors. Where is the facial going to be?
What do you use?
So do you graft that?
Yeah, this will be grafted. This is grafted, yes. That you will not allow nature to form because the soft tissue is going to sit.
Yeah, exactly.
So you have to graft this. You have to graft it, yeah. So if you do this, I'm going to draw a line to make sure I don't cross that line. If you cross that line and go very close to the facial plate, this is what's going to happen. The metal is going to show through at stage 2. You can see. Right? So where should the implants have been placed? The implant should have been placed along the singular line. It should have been placed here. It should have been placed here. Okay, so damage is done. So that's again part of your immediate placement protocol. Okay, so these are all going to be problems. So coming back to our single tooth, you said, how do I go about a single tooth? So your patient says, Doc, I don't want to spend extra for Maryland Bridge. The goal option, the ideal option would be to do an immediate placement. Okay? And the patient's traveling, not available, I will not do immediate load. I'm just going to go and close it. Okay? This happens to be an accident case. They won't cover anything else. So I'm just going to let this stay with A, and look at the diameter. Narrow diameter, good bone, no platform stitch. I'm closing it up. Grafted, no membrane, close it. Routine. And the patient's given a flipper. Right? You see the flipper, Doc? You see the difference in the flipper? Yes. The flipper is sitting just on the crest. You will have no incidence of any kind of inflammation. I don't believe in placing a healing abutment in this aesthetic zone. Okay, so at stage 2 is where the magic begins. At stage 2, I have a full flap to play with. I can decide how much of extra facial thickness I need. I can move this and create my contour. So when I do this, I can push this out, okay, and then I can even make a provisional if I wanted. Otherwise, I can go right to my final case. So look at this. No platform switch, porcelain fused to metal restoration. Look at the diameter compared to where the tooth was. That's why I said 3 millimeters beyond the apex. Intimate 2 millimeters from the tooth. Running room. This 100% will give you a papilla. And you can see it on the case. Okay? So it's not just one, every single case. What about this case? Tooth number 7 is going to be extracted. Where's the soft tissue? The soft tissue is here. Would you put a healing abutment here? Absolutely not. Would you put a provisional? I wouldn't even bother with the provisional because that recession is going to be worse if I put something on. In fact, I want the tissue to grow down. So the best solution in this case would be what? 2-stage. You can never go wrong with 2-stage. Give a Maryland Bridge. In the anterior zone, as you're getting started, don't play around with the implant. Let them heal. And I'll show you techniques to do stage 2. So this is almost 21 years ago, external hex, extracted the tooth, and that's your final crown. So all that happened at stage 2. Okay, nothing fancy here. So 20 year post-op, you can see how you can create the soft tissue profile. I'm telling you, the aesthetics I got 20 years ago is superior to the aesthetics I'm getting today.
Why?
Because they're confusing every day with different materials. One implant is subcrestal, they have this platform switch. The aesthetics, in fact, with simpler design, was far better. I had less headaches to deal with. Now you got this digital impression, you got this digital flare. I'm showing you all the problems happening with digital technology because people are lazy. You don't want to put your heads to think and plan. Okay, I'll show you my recent cases. I'm not happy with these newer designs that are coming out for the simple reason the variables are too many.
So why not just do it the way you did it 20 years ago?
That's why I'm going back to square one. Exactly. So I'll show you some of my older designs are still the way to go. What they way to go because of the fact it was a simpler protocol to follow. Do you see any platform switch here? Nothing. And look at the soft tissue. Okay, I'll show you case after case. This is number 8. Look at the tissue around the cervical margin. Is it inflamed? It's not good, right? It's crumbing. And this is the root that's going to be extracted. Okay? So, long implant. I'm going to show you the video for this. Okay, so this is at stage 2. What would be better? To have a full tissue, right? So now you can play with the soft tissue. And then at stage 2, I can do a provisional. Look at the provisional. Is it looking as wide as the original? No, I'm making it narrower. Why narrower? because the tissue can grow in. If I kill the tissue on day one, because I'm not presenting at Greater New York meeting, this is narrow. So this can fill in better. And then when I'm switching to my final, we take our impression, you will see our benefit here. So again, look at the design. So this is why I say, place your implants. If this is your CEJ, you can see where the CEJ is in relationship to the bone. And if you have this profile, you will not need any kind of aggressive design. This is implanted at 2007. And this is the fourth design I'm showing you. Okay? Look at the tissue. What is magical about it? Nothing. Nothing I showed you here is difficult for any of you to replicate. But don't keep changing your anatomy. If you're doing two-stage, do it two-stage. Take your time. You want to be able to get this off. So I'll show you the video of this case. Okay, so I'm going to extract this tooth. I'm holding my index finger and thumb. All right, so we make sure that we get the temporary off. See, my thumb is pressing against the facial plate. If I can't get it out easily, I'm using piezo. If you don't have piezo, use a scalpel. Scalpel will work just as good as a piezo. So I've got the tooth out. Okay, so now the next question is, do I need to raise a flap or not a flap? It depends on whether there's fenestration or not. If there's fenestration, 100% raise a flap. If the facial plate is intact, no fenestration, no adhesives, keep it closed. Okay? So I've got the socket curetted. There's one thing you want to do after extraction is curette. Multiply it by 10 times. Curette, 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 till there's no tomorrow, because that's your key. If you can remove all the strands of fibrous tissue, you will be ahead of the game with the success. So got this out, and then let's look at the first drill. So now I'm measuring. You saw what I measured? I measured 30% from the apex. That's my diameter, because that's what's going to engage. There is no place to engage on the crest, because it's a big hole, right? So no part of the titanium is ever going to engage the crest till 60%. If it engages, then you're doomed, because that means the facial plate will resorb, the metal will show through. The only part that's engaging is the apical 20-30% and the palatal wall. That's it. Okay? So now I measured
You measure the tooth to select your implant size?
That was what it is. Yeah.
So your implant size is going to be 30%?
From the apex, a third from the apex.
So
You see what I measured? And then now look at the direction of my drill. I have my index finger on the facial plate. Why? Because I want to feel the vibration of the drill. So if I vibrate, that means I'm very close to the facial plate. All right? And look at the direction. This long axis of the drill should not cross the facial of the adjacent teeth. Right? So if you have the tooth like this, two adjacent teeth, my drill will never go like this. I'm always going to keep it like this. And I'm drilling at the expense of what? The palatal pillow. Correct.
Now, what have you used to initiate?
Will be a lance drill. Lance drill. Okay? I'll show you another video how to start it. And look at the RPM. 300. Because there's nothing to cut. What are you cutting? You're not cutting dense bone. You're cutting only at the tip. So don't go at 1200 RPM and destroy whatever is there in the apex, because you are fashioning the APCs. All right. So be careful, because this is all customized. You control the cutting characteristics, and this is not with denser burr. This is regular osteotomy. And look at, you need steady hands, because the burr is going to wobble, right? Because there's no speed here. It'll start to wobble. So hold steady, and this is a 3.4 drill that's going in. And what's the length? It's a 13 mm length. So how deep should I drill? And what's my reference point? It's a 16 mm drill at the CEJ, which will put the implant at 13 mm. You see, that's the measurement intraorally you're trying to do. Because the drill has numbers. I want it 13 mm, that's 3 mm beyond the apex. And where should I end the platform? The drill tells you that this platform that you have there, so you see the platform there? So this platform is in line with the CEJ, which means the platform of the implant is going to be 3 mm below the CEJ. The 16 mm line is in line with the CEJ. Okay?
So if you're using Zimmer, you can bypass you have to bypass the pilot drill then, use the second,
Why?
'cause
The
it's too
pilot
short.
you should always use.
Zimmer has they have two drills.
There's 2 lanes, the pilot drill.
Yeah.
Oh, for the pilot drill.
No, but why use Zimmer? Why you can use any lance drill to your starter. That's why I said buy a new set of drills, because that can be universal for any system. Zimmer doesn't have the long pilot. It's a gold color. If you put a drill extender, then it becomes too long. Right? So sometimes it won't reach the apex. So use a lance drill from any company. You can buy it from Salvin. Salvin has a lance drill. Or get it from Densaberg. Okay? Alright, so this, you're all familiar with the Zimmer drill, so you can see. And what's the RPM now? 35, 50 RPM, that's it. Right, so that's a 3.8 drill. That's a 4.4 drill, just to touch it. And you can see the drill doesn't cross the facial. I keep repeating it over and over again because that's our biggest aesthetic nightmare. By taking the drill slightly to the facial, you ruin the facial aesthetics. Okay?
Then you can take it to palatal, you can perforate.
That's right, you need to.
Yeah.
What do you need? You need a CT scan. So now I'm placing graft on the facial alone. And why ahead of the implant? Because it's very hard
Yeah,
to
you
pack.
get it down.
You get it down.
Yeah.
And what do you do to ensure that the bone does not fill the osteotomy? Take the burr, go back and clean it up.
So then when do you use immediate? If you like second stage, if the patient doesn't care, do you always do second stage or?
No, when do you immediate? Patient demands. When the patient's demands go up, what goes up? Your fee. If they can afford it, I am ready to do it for immediate load.
So you will?
I will. I'm not saying don't do it. I said don't get into trouble if you're not getting paid what it's worth.
Yeah, it has to be.
So you would, gold standard though, you personally? if
My
they-
gold standard is the least I touch the implant, I'm better off. The more, it's like this. Think about the predictability. Which is the most predictable site? A heel bridge. Second, least predictable. And the bone's missing, right? Most predictable is when you have all the walls intact, good bone. Second would be an immediate placement where the bone is less. The third is immediate placement with the infection.
Oh,
All right. Fourth is immediate placement and immediate load. Immediate placement and immediate load. Okay, so if I want to get this, all the stars have to line up to be able to get this in at the same time. Is it predictable? It's predictable if the case selection is good. And I'll show you where I would do immediate load. Okay, if the patient demands it, I can make it work, but the other parameters should also be available. Okay, so I'm closing it. All right, so after I get the screw test, this is a screw test. What's the driver test? When I put the driver in, the driver should not stick out. The driver should not go in this angle, because some implants come with no mounts. When you have no mounts, you don't know the direction and the angle. In immediate placement, the implant can always go in a different direction. Right? Because you start like this and slowly it will start to migrate, because the implant will go in the path of least resistance. And the drill is smaller than the actual implant. So you can have a change in the trajectory. So now I'm placing the screw. The screw is going towards the incisal edge, right? Parallel to the incisal edge. And it's going to end about 3 millimeters subgingival. And then I'm packing some bone around the edges, and I will get primary closure from this.
So you didn't care about torque values here?
About?
You didn't care about torque values here?
But as the implant is going in, my hand has 50 newtons of torque.
50?
50 and more.
Very strong.
Yeah. You can actually break an implant with your hand. torque value on the fingers will only give you 6 newtons of torque.
I thought
But
it
your
was-
wrist,
Oh, okay.
with the fingers, nothing.
Yeah.
With the hand, you can go beyond 70.
Mm.
Alright, so this is how,
Fingers, I think it says like 15.
I think.
With your,
really hard, you cannot go. We had a test in the AID meeting. 7, one guy did it to 9, that's it. That's the maximum you can go. If I torque a prosthetic screw at 20, you will not be able to unscrew it with your fingers.
Yeah.
Yeah. Yes,
And so after you finished your implant placement there,
no scoring the periosteum, getting closure.
are you putting a membrane
Membrane,
over?
if I get primary closure, no membrane.
No membrane.
If I don't get primary closure, then I put a resorbable membrane that will last about 4 weeks.
And what are you packing in around the implant?
Just the same bone that I used at the apex. It is a cancellous bone that I use. Okay, so a spongy bone, it's hydrated, and I pack it around. So that is a byproduct of your 2-stage procedure. Can I do that as a 1-stage? Yes, you can do it as a 1-stage provided you get your torque values right at the same time. So this again is a 2-stage procedure, and this time there is closed root proximity. So you cannot use a piezo. Okay, so what we do by extraction, you would take your scalpel and then you would gently remove the tooth. Okay, see the length of the tooth. And that's another burr with the extender. I'm measuring the tip. The diameter is again calculated. Placing the graft, placing an implant. This time it's a different design. It's a hydrophilic implant. And you can see the blood covering over it. Don't get too carried away by this, because it doesn't do much. After about 3 minutes, it stops. Okay, so then I don't get primary closure. So I'm placing a resorbable membrane, closing it up. Again, look at my provisional. My provisional just sits on top passively. I don't want this provisional going into the gingiva to create any kind of emergence profile. Emergence profile is created at stage 2. You cannot create emergence profile in immediate placement. Remember that. Emergence profile means the continuity of the platform to the prosthesis is in one uniform contour, which mimics natural contours that cannot be contoured with a removable plate. Okay? The removable plate will destroy, because the plaque that will be surrounding the flipper will cause disruption in the healing. Okay? So you can see this is a very average, straightforward case. It's a 5-year follow-up. Look at this. This is a titanium abutment with tembon. And the margins right there. There will be no incidence of periimplantitis because zinc oxide eugenol is very kind to the tissue. What do you put in periopac? Periopac is zinc oxide eugenol. And what's tembon? Zinc oxide eugenol. Yes?
When you make a provisional,
Yeah.
in like stage 2, how long do you leave it in for?
How long do you leave it for? There is no magic number. Depends on the patient's hygiene, depends on how good the tissue is. I've taken impressions as early as 4 and I've delayed it up to 10. So there is no one formula. How long do you wait after crown lengthening? How long do you wait after crown lengthening to take an impression for a crown? Textbook will say, some textbook will say 4 months, some will say 3 months, but me, your patient's waiting with the provisional. You take it the very next day, right? Most of you do it after crown lengthening, you wait for 4 weeks and you take an impression. You look at the tissue, it's not bleeding, nice and tight, why can't you take the impression? So it's on a case by case. I would be lying to you if I told you, oh, just wait for 12 weeks. It is case dependent. Thick biotype, good tissue, you can go ahead and take the impression in 4 weeks. Okay? Another case. So what would this be an indication for? I'm going to extract tooth number 9. Will it be 2-stage, 1-stage, or put a healing abutment? 2-stage. In this case, you all know by now, it is going to be 2-stage because I can get outstanding aesthetics with the negative architecture. No provisional has got that bioelectric effect to pull the tissue down. Okay, so I'm going to extract this carefully. All right, so another implant design. So I'm going to get a closure. We're gonna retreat number 8 while the implant's healing, again another flipper. So at stage 2, look what happens. You can see the metal, right? The metal that is shown here doesn't bother me because my incision is here. Once my incision is going to the palate, I'm going to push this to the facial. I'm making a provisional narrower, okay? And then we get our impression done, and there you see our,
Can you go back, what, because every case like that, can you go back,
which one? You mean the
next
tooth
one,
or the,
next one, with the, no, with, when you said the palate.
oh, the palate?
Yeah.
Okay, so this is what you do. You go from the palate, full thickness flap,
Okay.
okay? And that fenestration will close itself. You can revise it and close it. Okay? And then we get our soft tissue. Look at this is what I'm looking for. I'm looking for this space. So there is no room for fat implants in the aesthetic zone. So if I have this, my crown design would be like this, which will provide me an amount of soft tissue like this. So now I can have a platform switch, not have a platform switch. The platform switch will not give you the aesthetics. Yes?
When you're doing second stage, do you do papillary sparing incision or
You
just?
include the papilla. I'm lifting the whole papilla.
Do you ever do papillary sparing incision?
No.
Why not?
Why should I? Papilla sparing incision, I'll tell you the reason why you should do papilla sparing, papilla unsparing, okay? So think about the reason, the only time, so just, if I do a papilla sparing incision, I'll get you to this, okay, sorry. You mean at stage 2, right?
Or even in, I saw your, in.
I always
you
go
don't
full.
use the,
I go full, so just look at this. Now, during placement, if I do a papilla sparing incision and get this done, right? I have to raise it, so if there is a facial defect anywhere, I should first know what is the area of the defect. And then I'm going to pull this all the way down to get primary closure. It's very hard to suture this friable tissue and try to get closure. That's the biggest problem. Right? The people who show you papilla sparing incision are all periodontists who deal with one tooth with everything intact. I'm not dealing with advanced destruction. So more tissue, the better I have to close. Otherwise, it will be friable.
And second stage.
And you can see at second stage too, I don't do papilla sparing for different reasons, okay? Let me get to this. Because you have to know what happens if you cut the papilla and what happens if you don't cut the papilla, okay? So, to me, this is more important. Of course, this is a lousy root canal, I'm not worried about this. Look at the placement here. The height and the depth. Okay, we're going to close this. So this tissue looks horrible, right? This tissue does not look anything like what you want to see. The facial thickness, this also cannot compete. This is nice and thick, this is deficient. So I have two options. I can do a soft tissue connective tissue graft and then build it up. Okay, so now at stage 2, if I performed a papilla sparing incision like this at stage 2, that tissue will tear, number 1. What am I going to suture it up with? If I have this opening, if I put a healing abutment, I have 2 clefts. How am I going to deal with these 2 clefts? You follow what I'm saying? If I did a papilla sparing incision, that little finger flap is going to open up. I have something here. How am I going to close that? So I end up with 2 clefts, which is what happened in the previous case. You didn't, I don't know if you noticed or not, but I don't want that clefting. So I'm going to go right to the palate, open this up, and wrap this all around. So when I'm finished with it, you will see that our tissue is even lower than where it is. I didn't lose the papilla.
So I did papillary sparing incision and I got the keratinized tissue on buccal, but only mid-buccal. So the interproximal looked like,
Defective.
yes.
Happens all the time.
So where would you
use
suture?
the papilla.
Where would you, where would your incision be?
What's that?
Where would you incision be?
Right?
Here I would not touch the,
No, before. Where was your incision? Can you
Yeah,
draw
sure,
it?
sure.
On
okay,
purpose.
I have so many I'm going to show you.
Okay.
One,
This is
this
mine.
one.
Okay, so now, what if it's an immediate load, right? So what are the factors for immediate load? This patient is a executive at Citibank. So she says, I've heard about Maryland bridges, I've heard about regular bridges, I just don't want anything, I want to have immediate load. Right? I can do immediate load, tooth number 9 is going to be extracted. Right? So I'm using periotomes to gently remove the tooth. I'm using periotomes, this was done in 2007. So this is my root. That root is valuable to see what kind of dimensions I want, because that's going to tell me whether I can do immediate load or not. So I'm measuring the length of the tooth, I'm measuring the diameter of the root, not at the crest, but about 33% from the apex. About 4.3, 4.5 is my diameter that I'm choosing. So curettage, make sure that the facial plate is intact, and I'm placing a 16 millimeter implant, aggressive thread. Okay, tapered implant, and 0 platform switch. 2007 we didn't do much of platform switch. This is a platform matched implant, in which I'm going to place the implant not 2 millimeters subcrestal, it's 2 millimeters equicrestal, because the implant design is scalloped. So you can see the shoulder of the implant is right there. Okay. Then what do we do? I'm making a provisional right away. Remember I told you, make my provisionals narrower. This is immediate post-op. Immediate post-op, patient walks around with this provisional. 4 months post-op, you can see the tissue nice and turgid. Okay, so we take our impressions at the fixture level. We're capturing the emergence profile. And that's how I got this case, which I showed you just a while ago. That's immediate placement, immediate function. Okay. And then I'll show you when would I do a papilla sparing. Okay, this is all papilla inclusive. So you'll see why I do a papilla inclusive incision. So this is at the time of placement. I'm doing a stage 2. I wanted to show you. So this is a C-shaped incision I was talking to you about. Right? C-shaped incision, the entire papilla is going to be lifted. I'm making my temporary crown with the temporary abutment. And this is the polycarbonate crown. You can see the 2 lips is present. If I had a papilla sparing, that papilla would have stayed where it is. Are you following it in terms of the reason for including the papilla? So now I have this provisional completely free and clear, so we can open this up and have access to the abutment. So this takes time to do. So after you have reduced the interproximal, so then this is where you would pick up the abutment. So now there is 360 degrees of spacing of the polycarbonate crown around your provisional abutment. So I'm using the same lead-on technique to capture the temporary abutment to your polycarbonate crown. This takes good 45 minutes. And this is not a billable visit. And what can you bill it for? And so that's why it's important that you include the fee for the provisional in the aesthetic zone. Right, so you can put a stick. This is our wax that I have over it. So wait for it to set. And once it sets, you will pick up the entire assembly. Right, and then you need to backfill it. So this opening, you can fill this void from the gingival margin. Right, so you got this filled up. Place it in hot water. And what's the next step? After it sets, you have to sit and carve it. Okay, so remove all the excess from the abutment. So you remember the emergence profile I was talking to you about? So that's what you need to control. That takes time. You need to sit and know where the negative concavity is going to be so that you don't bulk the facial. It's very hard to cut if you're using Luxatemp or Flow. And that's why this is a laborious procedure. I mean, you can use, if you have a 3D printer, you can do this.
Is this acrylic?
This is acrylic.
You said 45 minutes?
Wait a minute.
This would be 6 hours.
That's for your first one. After that, you'll speed up. You see that advantage? Now you have the bulk, and then you have the lips coming into the embrasure. See that? You have an abundance of soft tissue.
You have a suture through the papilla.
Through papilla, yeah. And then you'll see how it heals once it's all done. And this is free papilla, right? It's not. Okay, so there you finish it and polish it. Okay. What about cases like this? What do you think is happening here? It's a Band's resorption of number 9. Okay? Another way of handling this is completely destroyed. Entire distal is completely resorbed. So you basically have a shell of the tooth. And there's resorption here. So there you can see the papilla. So in this case, where you see papilla like this, no flap whatsoever. Okay, so I would try to minimize my flap. So after extracting the tooth, you're going to palpate the facial. The facial is going to be lost. You can see when I curate it, the whole facial plate is lost. Earlier I told you, we always raise the flap when you see the facial plate is not there, when it's infected or when there's granuloma. This is not an infected lesion. This is affected because resorption. Resorption is cellular, not bacterial. So when it's cellular in origin, you can go and do a close debridement. And now what are we trying to do? If I place anything into the socket, grafting, implants, what do I run the risk of? The soft tissue on the facial is going to percolate into the defect. So I need to have some kind of a barrier. So what can I use? I need to have some kind of a barrier. Should I use a non-resorbable or resorbable barrier?
Long-term resorption.
Long-term resorbable. Would you use a non-resorbable? Never. Never. Do not use a non-resorbable barrier membrane to the apices of the socket. You will get infection instantly. Right? Always resorbable. If you're going to do a socket preservation, resorbable is non-resorbable is okay. When you're doing an implant placement and a graft for growing the plate, always resorbable. Okay, so this is an ice cream cone technique. We use the membrane, place it at the apex, and then we would place the implant at the same time, no facial plate, and then we get our graft performed on the facial, and then you close it like a lid and suture it up.
How
Okay,
long
so
does it take for this barrier membrane to absorb?
8 to 12 weeks.
You really
What's the plan?
This is Biomed Extend. So you have any collagen. See, there's no trick to membranes. You should know the types of membranes, right? What is the purpose? Types of membrane, duration. Okay, so when I am dealing with a socket preservation, it's a graft. So since you brought it up, I'll go to the grafting sequence so you know exactly what we look for. So what can we do about this tooth? Okay, so tooth number 30 is going to be extracted. We'll review the membranes and then we'll go to immediate placement after that. Okay. So I want to extract tooth number 30. 30 is being treatment planned for extraction because there is a radicular perforation, and the patient's really keen on having this replaced with an implant. So what would you follow? What's your sequence for extraction?
The actual extraction?
Yeah, actually, I mean, let's do a role play. Let's say this patient's
Remove
coming,
the crown, section the roots,
and then,
then lux,
and then,
curate,
okay, and then, How do you know that? This is your case.
Oh, then check the plates.
Evaluate the
Okay, and then?
plates on the
If
side.
it's intact, then
You can,
you can place more implant. If
but
there is-
shouldn't you know this looking at the radiograph? So how would you diagnose whether the case is suitable for immediate placement, grafting, or nothing? Because this is affecting your clinical practice. Patient comes in, do I send for a pre-D? Is the patient going to be coming in for immediate placement? Am I going to charge? Because your front desk wants to know what to bill. You have the appointment already set. So before the appointment, you should have your homework set so you can know exactly what happens on the first visit. Otherwise, it's going to be anybody's call, right? So if I have this radiograph, what are the options you have here? Is this the case for immediate placement?
It is chronic infection, right?
Chronic
So
infection?
no like acute process.
No contraindication for that.
You look like you have decent.
You can. Okay, so tell me the technique for immediate placement. First of all, immediate placement is going to be predicated upon getting the tooth out
2,000.
properly. So if you tell the patient, please bring me $2,000 in the next visit, and you break the buccal plate, oops, I don't think I can do an immediate placement.
You can
You should
tell
know
him that
this.
he has two options.
There's two options, so
So if
but,
I extract and
Yeah.
everything is okay and buccal plate, I mean, I won't say to my patient if buccal plate is in place.
so then,
If I believe that I have
how would you know
enough
that at
bone,
this stage?
I mean, I can tell to my patient that bring 2,000 with you, but since I really say this, I
Is
mean,
it, can you say that?
because in our country they just pay, you
Let's
know,
talk
like,
about-
so they should pay this
Well, you
visit.
can
Our
So-
patients are more demanding.
Yeah.
You can say I'll try my best, but if the
I mean-
Never use the word, I'll try my best.
No, I mean, if I will.
This is it, because then it's trying, you say, you know, because it impacts upon your ability to prognosticate, your ability to predict. And that's what separates you from the average GP.
But how can you predict if you don't know how the
CBCT.
surgery is gonna go?
You can tell from the radiograph.
How do you show it? How do you
That's what
tell?
I'm showing,
Because
okay?
it's
So when you look at the radiograph, you need to look at, do I have all the information needed to be able to execute the surgery?
Do you think that an apex code is late because it's open really not?
So that is depending upon your surgical skill, right? So first of all, the options are immediate placement versus extract.